When a patient is crashing, the chaos of the room can be overwhelming. Alarms are sounding, multiple people are talking at once, and time is working against you. To avoid freezing up, medical professionals rely on a rigid, standardized system. That system is the Abcde assessment. It allows you to systematically evaluate any acutely unwell patient, identify life threats, and fix them in a specific order. Before you even begin the letters, there is a mandatory prerequisite check. You must immediately confirm the patient has a pulse and is breathing. If they are completely unresponsive and not breathing, abandon the Abcde framework. This is a cardiac arrest, and you must start CPR immediately. If the patient is breathing, you can begin the assessment. The golden rule of the Abcde method is that it is an assess and treat model. If you find a problem, you must completely fix it at the current step before advancing to the next letter. The sequence is strict because it ranks by mortality risk. An airway obstruction will kill a patient faster than a breathing issue, and breathing issues kill faster than circulatory failure. You work from the top down. Step 1 is airway. To assess it, simply speak to the patient. If they reply to you with a clear, normal voice, you have confirmed their airway is patent. If the patient is completely silent, or if you hear added noises like gurgling and snoring, the airway is compromised. You need to perform an immediate visual check inside the mouth to identify the obstruction. Use suction to clear away any visible secretions. Then physically open the airway using the head tilt chin lift maneuver. This action lifts the tongue away from the back of the throat to reopen the airflow passage. There is a major exception. If your patient has experienced trauma, manipulating their neck with a head tilt can cause lethal spinal cord injury. In these cases, the jaw thrust maneuver is mandatory to protect the cervical spine. Once the patient is breathing quietly without any adventitious upper airway sounds, you have secured their most critical lifeline. You can safely move on. Step 2 is breathing. Observe the patient for bilateral chest rise and check for the use of accessory muscles to force air into their lungs. Then listen with your stethoscope for wheezes or crackles. Next, check your quantitative metrics. Count the exact respiratory rate for a full minute and check their oxygenation by placing a pulse oximeter on their finger. If their oxygen saturation drops below 94%, apply supplemental oxygen immediately. If you hear severe wheezing, administer a nebulizer like salbutamol to open the lower airways. For mechanical respiratory failure, where the patient is barely breathing or visibly tiring out, you must take over. Use a bag valve mask to manually assist their ventilation. Treating breathing issues early reduces the physical work of respiration. You are ensuring oxygen successfully enters the blood before you evaluate the cardiovascular system. Step 3 is circulation. Here, you assess tissue perfusion and cardiovascular stability. Measure the heart rate, obtain a blood pressure reading, and note their urine output, which is a primary indicator of kidney perfusion. You also need to test central capillary refill time. Press firmly on the sternum for 5 full seconds. Release the pressure and count the exact seconds it takes for the color to return. A capillary refill time longer than 3 seconds, or a dropping blood pressure, indicates active shock. Blood pressure is often the last vital sign to fall, meaning the patient is reaching the very end of their physiological reserve. You must intervene quickly. Establish large-bore IV access immediately, start fluid resuscitation, and apply firm, direct pressure to any active external bleeding. Circulatory interventions are about volume and pressure. If the pipes are empty or leaking, the oxygen you secured in Step B cannot be delivered to the brain and vital organs. Step 4 is disability. Begin your neurological assessment by using a pen light to check if the pupils are equal and reactive to light. When you lack the time for a full Glasgow Coma Scale calculation, rapidly grade their level of consciousness using the AVPU scale. Note if they are alert, responsive to voice, responsive only to pain, or completely unresponsive. A capillary blood glucose level must be obtained for patients presenting with an altered mental status. Hypoglycemia frequently mimics primary neurological trauma and must be ruled out immediately to avoid misdiagnosis. Intervene for metabolic or toxic deficits. Give oral glucose, IV dextrose, or IM glucagon for hypoglycemia. For pinpoint pupils and a low respiratory rate, suspect an opioid overdose and administer naloxone. Many acute changes in consciousness result from reversible metabolic deficits. Identifying and treating these imbalances can return a patient to their baseline in minutes. Step 5 is exposure. While maintaining the patient's dignity, briefly remove their clothing to perform a full-body visual sweep. You are looking for hidden physiological threats. Inspect the skin for obscured rashes and hidden bleeding, surgical wound complications, or peripheral edema in the legs. Measure the core body temperature. If the patient is hypothermic, treat it rapidly, using warm IV fluids, blankets, or a bear hugger to bring their temperature back to normal. At the opposite extreme, identifying a high fever paired with a suspected infection is a major red flag for sepsis. This requires the rapid preparation and administration of IV antibiotics. The exposure step is your final safety net. It guarantees that no hidden underlying pathology will sabotage the stabilization you achieved in steps A through D. By reaching this point and fixing issues along the way, you have systematically evaluated and stabilized the patient. The Abcde assessment is not a linear checklist. It is a continuous loop of reassessment. If the patient deteriorates again, or after you administer a major treatment, you must go directly back to step A and reassess. Finally, use the comprehensive data gathered during the Abcde sweep to call for senior help. Hand off the patient to the next provider using the structured S-bar framework. Following this system provides a clear pathway through the chaos of a deteriorating patient. By systematically ruling out life threats, you significantly reduce the risk of overlooking critical pathology in a high-pressure environment.